5, 4, 3, 2, 1. We are live now, sir.
Good evening, everyone. Welcome to the platform of Orthopedic Research and Education Foundation India. So this is the class about the tips for attending table Viva in practical examination for orthopedic postgraduate. And the speaker today is well-known Professor Ananda Kisor Pal, sir, is former HOD for orthopedics in IPGMER and also SSKM Medical College, the Center of Excellence of India, Kolkata, West Bengal. So over to you, sir.
Good evening. Good evening. It is my honor to have this platform for spreading the knowledge among the postgraduates, and as I'm extremely benefited also because it is a two-way platform for learning and also the teaching, and I'm very much indebted to the Professor John Mukhopadhaya for his continuous initiative, and also this Janki Sharan that is a extremely academic and dynamic person for conducting this for every Tuesday. So this is extremely difficult. I think is a very good initiative for the postgraduates. So without wasting a knowledge, I'm starting with my this today's topic. At least after discussing at 30-40 minutes, I love to have the interaction. And my topic of discussion is today is facing the table Viva in a postgraduate orthopedic examination. So because table Viva is extremely important because especially for the DNB students for passing on for the postgraduates of MS Orthopaedics also it is important because sometimes in the clinical part they are doing little bit so they may be a little bit less exposed, but for the table Viva if it is doing very well, that creates a very good good image for the examiners and for the passing also. And not only that, this is also very helpful for postgraduate students just after passing to impart the knowledge for this. So what are the options for the table Viva? Because basically, in most of the centers, there are 4 table Viva. So there is 5 items are given here. But actually, this is actually according to the guidelines of the NMC. But these 5 items, sometimes it is 1 or 2 items can be intermingled with each other, and that is how it may be 4 tables. And in most of those situations, there are 12 number of divided into all the 4 tables. So first of all, I'm start with osteology because it is very extreme basic. So sometimes it's one bone is given to the patient student, and it is asked. There are several questions. Now, what are the normal questions usually asked for this the cadaveric? So first of all, we have to always this is the tips for all the students. So once you have given any bone, always hold the bones in an anatomical position. This is most important. So sometimes it is a right-sided bone or the left-sided bone. So always you have to hold the bone in a normal anatomical position. This is extremely important. Suppose some articulated pelvis can be given. Similarly, pelvis should be held in a normal anatomical position. This is extremely important. Now, once you have hold it, then you have asked what is the name. You can start telling with that name, course, development, anatomical position. I've already told muscle attachment. The examiner will ask about the relationship with the major vessels and nerves. Suppose it is proximal humerus. Now the examiner will ask what are the nerves? They are coming very close to the bones, and what are the mention the areas of the nerve. The nerves are coming very close to that. So this is extremely important. Next is the approach to the bone for joint for any operation. Suppose I'm telling suppose femur is given. Now what are the approaches for approaching to the femoral head or the hip joint? Maybe ask. Now any special characters, special area of interest maybe ask for that. I will come. Or sometimes it's different axes. Sometimes anatomical axis, radiological axis, how it is drawn, how it is drawn. That may be asked, or landmarks for insertion of implants may be asked. Suppose tibia is given, you have to ask for the entry point of the interlocking nail, difference between the medial lateral tibial plateau, ligaments like the different ligaments, what are the ligaments may be attached in the intercondylar notch, interarticular space like tibial spine, posterolateral corner. Now, IT band. What are the attachment of the IT band? What is the administratively situated? That may be asked. Now, next is the anatomical approach. What are the different anatomical approach in different tibial part to fractures, proximity of fractures? What are the different classification system? Medial and lateral surface of the dark. Vascularity of the distal tibia, or the what are the areas which is known as the pylon? What are the syndesmosis? What are the different what are the syndesmosis called? And now what are the areas especially used for the syndesmosis and ankle injury? Suppose I'm giving the example. Now, suppose the tibia, they may be asked, what is the exact entry point of the interlocking nail? So this is the answer. In the frontal plane, the entire point is located in line with the medullary canal. That is 3 millimeter medial to the tibial crest. So if the tibial crest is here, there should be a little bit medially. It should not be. The actual point is should not be lateral to the tibial that is tibial shin. This is most important. Another is if in the sagittal plane, if you see this in the sagittal plane, the entry point should be located just distal to that junction. There is a tibial plateau and the tibial metaphysis. So suppose this is the junction, and your entry point should be just distal to it. So that is the exact entry point of the interlocking band. And as you can see here, see this is the tibial shin, and this 3 millimeter actually this is arbitrary. You should be little bit medial to that. This is the point actually, and how it enters. If it is an intrapatellar entry, then it will be either through the lateral. It is a medial border, or through the junction of the lateral 2/3 and the medial 1/3, splitting the ligamentum patelli. So this is the answer. Now, if the femur is given, now you may ask, what are the entry points of the interlocking nail? What are the entry point of the PFN or the Recon nail? Now, what are the importance of the lesser like this? So the hip capsules, I'm not going into detail. So see this, suppose this is the insertion point. So this is the most important. What are the entry point of the Recon nail? Suppose see this is the Recon nail. Recon nail should be actually Recon nail. It should be actually the midpoint between the anteroposterior. If we make a this line from the anterior to posterior, Recon nail entry should be at least or through the midpoint. But both the cases, it is a piriform fossa entry, because as you can see here, entry point for the interlocking will be posterior. So this is junction of the anterior to the posterior, but the Recon nail should be at absolutely, it is in the midline, and it is the anteroposterior and should have piriform fossa. Whereas in the PFN or PFN-A or PFN-A2, PFN-A especially, it is a little bit 6 degree lateral to that. So that is through the tip of the trochanter, anterolateral or lateral trochanter. And it should be, if we see the anteroposterior, it may be either it is the midline or little bit anterior, because it has no, but this PFN doesn't have any much more bow, anterolateral bow, so it should maybe little bit anterior, can be taken. Otherwise, if it is a Recon nail or PFN-A2, PFN-A2 is basically this angle should be a little bit less. It should be either through the tip, or it can be through the piriform fossa. It should be 5 degree. I will come in that instrument set. But for the PFN, ordinary PFN is the first generation PFN. It should be a little bit anterolateral. So technically it is easy, but the point is, if the lateral wall is shattered, then the PFN-A is very much disadvantageous. And some authors claim that this PFN-A may consider as a part of the lateral condyle, but that may not be the actual scenario. So in that case, if the lateral wall is shattered, then we can go through the little bit medially with the help of the PFN-A2 or the Recon nail. So this is the area. I'm not going into detail. Suppose you may be asked, just draw the incision. Where do you put the incision to reach the femoral head? So it may be either H-shaped like this, or the I-shaped, or you may be asked, mark the incision where there is a least amount of vascular damage. So this is what is the incision? What is the actual line of the incision where we can give the maximum respect to the lateral epiphyseal vessels to preserve the blood supply of the femoral head, that is during the safe surgical dislocation. So that is the incision. See, this is the anterior, this is the posterior. So yeah, this is the flip. Osteotomy can be done through the trochanter, where the part of the trochanter is elevated anteriorly. And in that case, you can see here the incision should start from this area. It is anteriorly, go towards the base of the neck, base of the head, then comes posteriorly like this. So this is looking like almost a jet-shaped incision, so that this area which is carrying the most vascular, and that will become preserved. So this is the incision. So the same incision may be asked. Suppose it is a distal femur, maybe in the femoral part, you can ask what is anatomy, what is the deforming forces in a supracondylar fracture, what are the choice of the implants for supracondylar or intercondylar fractures, what is the entry of BFN or the other metals. So suppose this is the DFN. If it's anterior in epi view, the center of the guide wire should be exactly at the middle of the intercondylar notch. On the lateral view, it should be located in the extension of the Blumenset line. Or see, this is the triangle. See, this is the triangle, and triangle, it should go through the apex of the triangle. And what are the other insertion point of the other metals? So this is actually, it is given in the AO books. You can, if anybody can take the reference for this. Now the axis. What are the, when we've been asked either to the femur is given, what are the axis? So this is the midline. This is the mechanical axis, this is anatomical axis. Mechanical axis is 3 degrees midline, but the anatomical axis is 6 degrees. So it is 90 degrees from the midline. So this is the actual, this is especially used for the deformity correction of the pora, or the pora formation. Now the radiographs, once you get the radiograph, always hold it in front of the light, and we have to identify the radiograph, whether it is a standard radiograph or not, whether it is adequate radiograph. Then you have to start describing, then you have to give the diagnosis, and once we have give the diagnosis, stop it. Then let the examiner to ask why you are telling this diagnosis. Then next question will be what is your differential diagnosis. Next question may be what is the next investigation of choice for confirmation of diagnosis. Next, what are the management. So we can start with this like this. Now, so describe systematically and the pinpoint the broad spectrum diagnosis should be given. Now, what are the how to read the radiograph? So in a previous class, in a radiographic class, I've already, as I stated elaborately. But in this class, I'm going to the nutshell. What is the ABCD of the radiograph? Basically, ABCD in the film, it may be whether you have to see whether it is adequate or not. So it may be you should see whether it is alignment, and the rule of two. Rule of two means of the two views, the two sides, at least in the two joints. Suppose the femur, you have to take the joints. That means of the hip joints and the knee joints for proper diagnosis. Two sides epilateral view. Sometimes two views, two view epilateral. Sometimes two sides, right and left sides, both the sides may be required to, especially for the pediatric cases, so to see whether there is epiphyseal injury or not. And sometimes two occasions, especially for the scaphoid or any other small short bone fractures, two occasions may be required. And two spatial view may be required, like extraction view or some stress view may be required for some diagnosis. So always there are some rule of two. This is most important. Next, B for the body and the course, that the 3 point and the 4 densities. So they are not going to detail. And lastly, the dates. This is for the film. For the patients, we have to see whether the age, whether it is a mature patient or immature patient. We have to see the background. If it is possible, then the disease, we have to see for the background of the disease. Next, some clinical finding, and also the side, is the right side or left side or the both side. So rule of two, I'm already discussed. Now for the trauma. So suppose it may be trauma or the disease. So in the trauma, we have to see, we have to check the displacement. The next is the type and the classification. So in the displacement, how do you guide for that? In the displacement, it may be linear displacement, it may be angular displacement, or it may be rotational displacement. Linear displacement in 3 plane can occur, that like sagittal plane, coronal, the axial, supination, and impaction. Now, sometimes it is asked, how to differentiate between it is impacted or superiorly or inferiorly it is displaced. So in impaction, there's interlocking of the fragments in between each other. This is the impaction. Now in angulation, there are another two terminology. There's angulation and the tilt. How will you determine the angulation and tilt? I will discuss in the next slide. And the rotation also, there's a medial lateral, that and symmetry of the cortical thickening, and there are some bony landmark that will help to diagnose the rotational deformity. Now in the joint, we have to see whether the fracture is extending to the joint, whether it is subluxation or dislocation, or there is a pathological problem. Suppose this is the fracture, how to differentiate between the angulation and the tilt? In suppose this is fracture in the diaphysis, always we describe the angulation, or there is the juxta-articular fracture, we tell always the tilt. So how it is possible? Because it is a diaphyseal fracture. For the angulation, for drawing the angle, 2 arms is required. For the diaphyseal fracture, 2 arms can be appreciably, it is long enough. So it is very easily, it can be drawn. That is why angulation is the term is used for angular displacement. Whereas it is a juxta-articular fracture. As it is very, the one arm is maybe long, one arm is very short for diagnosis. So it is very difficult. And in that case, tilt is determined by the direction of the articular surface of the articular block. So suppose this is the articular block, as you can see here. See, this is the articular block. This is very small fragment. And see, this is the articular surface. And if we make this articular line, how it is located? You see, the direction is towards the lateral side. It should not be the ideal one. Normally, this direction should be on the medial side. So it is a lateral tilt. See how it knows the lateral or medial. See, note this thumb. Thumb is on the lateral side always. So it is the lateral tilt. So similarly, in this manner, see, it is a lateral view. See the articular block, and this articular block is directed towards on the posterior side. How do you know it's the posterior side? See, this is the thumb. Thumb is always anterior. So it is going towards the posterior side. So this is a dorsal tilt. So this is the lateral tilt and the dorsal tilt. Whereas the angulation is drawn by the line drawn along the superior and the inferior fragments, and the angle, the direction of this angle is noting dictated which angulation it is. So this is the medial side, is the lateral side, is the lateral angulation. Similarly, it is anterior and it's a posterior, so it is a posterior angulation. Similarly, there are different angles and lines may be drawn. I'm not going to detail. So one single thing just for the supracondylar fracture, I'm just one thing. So this is there are 2 important points. One is the Bauman's angle, another is the metaphysio-diaphyseal angle. So one axis is drawn along the axis of the humerus. So how the axis of the long bone is done. So this is the technique that is at least through the shaft of the femur, 2 points, 1 point to and another point. We have to draw it, make a midpoint. Similarly, at least 1 centimeter away from that, we have to make another point. This is 1 point, another point, draw it, this is about midpoint. So if we join the midpoint, so this is the axis of the humerus, axis of the humeral diaphysis. Now in the metaphysis, how to know which one is the metaphysis? Metaphysis is basically, it is drawn, it's a maximally wide area. See, this is the maximally wide area. So if this maximally wide area, this is the metaphysis, and how far zone of this bone is considered as a metaphysis. This is the answer is. So if you make this maximally the wide area and make a square of this, suppose this is 10 centimeter length, make a same 10 centimeter line over this, 10 centimeter line over this, and 10 centimeter line over this. So this is the area which is considered as a metaphyseal area. And now this is the metaphyseal line. Now this is the diaphyseal-metaphyseal line. So this is the metaphysio-diaphyseal line. Which angle is most important? This is the inner. See, this is the medial, this is the lateral. So this is the innermost part. This is the metaphysio-diaphyseal angle is most important. It should be ideally 90 degree. It should be ideally 90 degree. But if it is a 90 degree or less, but if it is a medial tilt, so what will happen? If it is a medial tilt, so articular surface is looking much more medially. So in that case, what will happen? This angle will become less than 90 degree. So if this angle is less than 90 degree, so it is more than 90 degree. If it is the medial tilt, this area, this angle will go up. This will go up like this. So that's if the angle is more than 90 degree. So if it is more than 90 degree, it is definitely it's a medial tilt. And immediately in post-reduction radiograph, you have to check for this metaphysio-diaphyseal angle, because Bauman's angle is very difficult to draw. And this Bauman's angle is drawn through this one line through the epiphysis, another line is the diaphysis, and then another is the right angle to that. And this is the angle. This is the angle. Just opposite. This is the angle. This is the angle is the Bauman's angle. So it is very difficult. But metaphysio-diaphyseal angle is very easy. If it is more than 90 degree, that severely it indicates it is a medial tip. Similarly, in articular block, how will you diagnose how will you draw the axis? Similarly, this 2 point, join it, make a midpoint, and if the midpoint is drawn along this is the axis of the articular block, and this is the anterior humeral line, and this line is although it is a 30 to 45 degree. If it is less than 30 degree, that it is a posterior tip, and this is the Malgagnis line. Any line which drawn along the radial head, that will always cut the center of the capitulum in all views. This is a Malgagnis line that will indicate the radiocapitellar relationship. And this is also Mubarak line. As you can see here, this is the Mubarak line. There are different lines. I'm not going to detail. Now, spot diagnosis. What is a spot diagnosis? This is actually trident hand. This is seen in achondroplasia, as it is very difficult to approximate. Why it is called trident? Because you see this line. This is the normal hand. But see, in this case, the diameter, the length of index, middle, and the ring finger is almost same. So if you flex it, it can be approximated. If you extend it, cannot be approximated because the fingers are stubby. It is looking like a trident. That is why it is known as trident hand. And what is the operation? That is basically this is a one operation. We can easily diagnose. This is done for the malunited distal radius fracture, and there is the one operation is done. Now, either we may be asked, what is the name of the operation? What are the different technique? What is the any modification can be done or not? So there are different types of questions may be asked. Now, for the disease, again, it is A, B, C, D, E, F. A for the adequacy, age, and the angle. B for the bone, that is, we have start from above, from outside inward or inside outward, like the soft tissue, periosteum, cortex, and the medulla. And next is the joints. And then you have to see the border lines. I already told what are the different border lines for noting the alignment of the joint. C for the central or the eccentric lesion. D for the density, it may be sclerotic, lytic, or the mixed, or the deformity. E for the whether it's a lesion is expansile or not. F for whether it's a fracture dislocation or not. So this is, suppose this is the case, how will you describe it? So eccentric, homogeneously lytic lesion in lower metaphysis of the femur with narrow zone of the transition. As you can see here, how the zone of transition. So the zone of transition is determined by whether this is the zone of transition. It may be very sharp or it may be very wide. See, in this case, it is very narrow zone. That means you can easily determine that this lesion ends here and the normal one starts here. So that is the zone of transition. So if it is sharp and sclerotic, that means it's always absolutely benign. Sharp and non-sclerotic, it may be either it is a potentially malignant or a very vascular lesion. Or if it is a very wide zone, that means, suppose this is the case, you cannot discern in which area it ends. So it is a wide zone of transition here in this area. That may be a malignant one or a very sinister significance. Now, if you get the instruments and implants, we have to take the nomenclature. So first we have to hold it in a useful position. So, okay. Suppose this is the case. How would you hold it? We have to hold it with your thumb on this thumb rest. So this is the position of holding. This is a functional. We have to hold it in functional position. So other points is we have to check the parts. What are the different parts with the utility? How to hold it? That is the one. If you hold it properly, then this one question is already answered. Now there are general use. General use, that is I've given the mnemonics. That is A, B, C, O. That means A for the amputation, B for the bone grafting, C for the chronic osteomyelitis, and O for the open reduction and internal fixation. Any general instrument, if you got it, take this A, B, C, O nomenclature. That means A for the, again I'm repeating, A for the amputation, B for the bone grafting, C for the chronic osteomyelitis operation, that means sequestrectomy and saucerization, and O for the open reduction and the internal fixation. So in these four operations, almost all of the common instruments are used. Now, if you detail it properly, then you come to the special use, next sterilization, and some modification of the instrument. And then in implant, suppose you have got any implant. So there's instrument and implant. You will get the implant. Always you have to identify it, take the nomenclature, then parts with the utility, the specific use or step in operation, and lastly the technique of that part. So this is a Farapus periosteum elevator. What is the purpose of this thumb rest? So let me be asked. So what are the other periosteum elevators? This is the Keys periosteum elevator, AO-type periosteum elevators. It will be asked. These are Bristow's. Initially, it was used for the elevation of the periosteum. Nowadays, it is not used for the elevation, but used for retraction, for maintenance of the retraction of the periosteum. Now, there are several other Bristow's are there. Now, there are several osteotomes like this. Now, different types of osteotomes. You may be asked what the different types. I'm not going to detail. Now, these are also spinal osteotomes. See, these are the spinal osteotomes. So you have to become ready to diagnose all this. Now, the different plates. So this is a 1/3 tubular plates. This is a recon plate. So this is a locking recon. See, this is ordinary recon, and this is a locking recon, whether it is a LCP with a combi hole. So these are first we have to identify it. Next, what are the different? Why you're telling it is a combi hole plate? What you are telling is a recon plate? It is a pelvic recon. How to differentiate the normal recon and the pelvic? Pelvic recon is relatively heavier. It is much more thicker. It is a normal recon, maybe 1 to 2 millimeter thick, whereas the pelvic recon may be much more thicker, maybe 3 millimeter thick, 3 or 4 millimeter thick. Okay. Now, this is the DCP. You have to identify what is the DCP. This is a DCP, and this is also a DCP, is a combi hole DCP, but it is maybe LCDCP. You have to check the lower part of the plate, and you have to check whether there is some excavation or not. And another important point is it is a DCP. It is a combi hole DCP. It is also combi hole DCP, but it's a staggered appearance of the holes. The staggered appearance. That means all the holes not in a single line. This is known as the staggered appearance. What is the purpose? Staggered appearance that will actually catch the medullary, that is the bony trabeculae in different parts of the bone, so that will reduce the stress riser inside the plate. So there's a chance of plate breakage is relatively less. So that is most important. Now, philos. How to identify the philos? This is the philos plate. How to identify? There are 9 proximal holes. The proximal is thicker than the distal, as you can see here. And there's an oval, large oval. Now the question is, why the large oval hole? Which screw should be, which hole should be used for screw insertion first? So that these are the different questions may be asked. What are the different types of plates may be asked? So this is a low profile MIPO plate that can be easily inserted in a deltoid splitting approach. So this is, what is the basic difference between this one and this one? So this is the main portion, and see the line of the shaft insertion is relatively away from the proximal humerus, whereas the line of the shaft is in line. So in that case, so if we make a deltopectoral incision, we can easily insert it, but in the deltoid splitting incision, it is very difficult because this lower part of the plate is come in line with the deltoid insertion. But in that case, as it is away from the line, the deltoid insertion is spared, so that it is a site specific. Okay. Now, similarly, there are different plates. So I may be asked which type of plate. This is anatomically locking distal humeral plate. Sometimes it asks which plate is the lateral one, which plate is the medial one. See, these are the post. If the posts are there, it is always most of the cases the lateral one, because the lateral condyle or the capitulum, it is little bit 40 degree, 30 to 40 degree anterior. If you see in the lateral side, 30 to 40 degree anterior. That is why. So some screws may be required to put from that anterior side. So that is why this bar is there. Whereas in the medial side, it is not anterior. It is almost in the line with the shaft. That is why these are all the medial plate. These are all the medial plate, but in the lateral there is a posts are there. Now the DHS, sometimes it is DHS is asked. I'm not going to detail. Specifically, it is asked when it is short barrel is used, when is the standard barrel is used, when in the short barrel, what is the actual screw length? Maximum screw length can be used for the short barrel, for the long barrel like this. What is the difference between the DHS and the CHS reamer? So you have to only this portion which is different. Now, what are the modifications? Modification is the made of sliding plate. Not going to detail. There are some Targon plate, or there's a waist plates device. You have to know this, because sometimes if you do very well, then the examiner may ask with this. Now, what are the different types of plate? This is basically, it is a proximal tibial plate. How to know that? because there is a cluster of holes in the upper part, cluster of holes in the upper part. Okay, and the distal part is the combi holes. Okay, so this is known as the cluster of blocking holes in the wider end and the combi hole in the linear fashion. These are basically, it is a distal tibial locking buttress plate. Not going to detail for the nail also. It may be asked, what are the different types of nail? What is the bend? See, this is the twisted longitudinal slot. What is the purpose? This purpose is to increase the shearing strength of this. So this is a specific, this is a special feature of the specific nail. You can tell that. There are different fashion of proximal locking hole. It may be asked in which condition we have to use like this. Okay, I'm not going to detail. This is the angle stable locking. So this is the modification. This is sometimes it is asked, what are some recent advances of locking, interlocking screws? This is the angle stable locking screws that can be used. There's a small polyglycolic acid slip is there. Basically, it becomes jam inside the nail, so that will cause angular stability. There are actually basically two sets of threads, the smaller threads that will engage the distal cortex, and the larger threads that will engage the proximal cortex that will also provide the stability. And this polyglycolic acid shell, this is a shell that will provide the excellent angular stability once it becomes jam-packed inside the nail. And the PFN-A and the PFN-A2, what is the basic difference? I'm not going to detail. There's one thing I just want to know. So now this direction is going to become oblique. This oblique direction is biomechanically superior than the transverse screw. This is the modification. Another is the difference between PFN-A and the PFN-A2. The insertion point, PFN-A is a little bit anterolateral. There is a larger, there is 6 degrees, whereas the PFN-A2 is only 5 degrees. So it may be in to the piriform fossa or just lateral to it. So this is most important. Another important is its diameter. See the diameter of the PFN. It is 17. It is a 16.5 special Asian country, and as it is little bit medial entry, that if there's some already the lateral wall is shattered, so in that case that doesn't provide some much more damage to the lateral wall. This is most important. Another CCD angle, there are several CCD angles that are only for the PFN-A2 is 125, 130. And another important point is see this change of the diameter is occurring just from the nail or the barrel junction. So this is the most stable component, and from that stable component, this change of diameter is occurring. So there's a high chance of shearing stress over there. There's a chance of screw breakage. Whereas in the A2, this change of diameter is little bit away from the screw insertion. So that is also biomechanically superior in comparison to PFN-A. So in unstable situation, we have to use the PFN-A2. Now, Orthotics Prosthetics, again, we have to start with the nomenclature. We have to hold it in its functional position. Suppose it is a walk-up splint, we can hold it in your hand also, so that the examiner will understand how it can be applied. Now, the next is the part with function, how to wear, indication, contraindication, limitation, complications, guidelines. Now, the prosthetics also, we have to check the nomenclature. Sometimes the Belloni prosthesis are not like that. What are the parts? Exoskeleton, endoskeleton, indication, contraindication, complications, guidelines. Now, it is very easy. This is because the international nomenclature for the lower limb, the joints encompassed by the orthosis, that determines this nomenclature. If it encompasses only the foot joints, it is the foot orthosis. If it is the ankle and foot, both the joints are encompassed, the ankle foot orthosis. It only encompasses the knee, that is the knee orthosis, like the hinge knee brace, or the long knee brace, or knee immobilizer. It is a knee orthosis. It encompasses all the knee, ankle, foot. It's like CAFO, or it encompasses the hip also. It is a H CAFO. If it starts with the spine, then an SH CAFO. For the upper limb also, it is a finger orthosis, hand orthosis, wrist hand orthosis, like that. For the spine also, it is a cervical orthosis, so cervicothoracic orthosis, lumbosacral orthosis. There is a dorsolambosacral orthosis, cervicodorsolambosacral orthosis, like the Milwaukee brace. Sacral orthosis is just like a belt we are using for holding our trouser, but at least for the sacral orthosis, the thickness should be at least 2 inches, 2 to 4 inches. Okay, so this is the now the indications. This is the universal indications. If you remember this slide, you can easily understand, you can easily tell in the examination. Basically, the three indications of the prosthesis. It may be weakness, like due to the UMN or the LMN policy, that is insensible part of the limb. Next is a loss of structural integrity, that may be due to trauma or the joint disorder or the inflammation or failed joint replacement. And lastly, it is a deformity. It may be either flexible or the flexible dynamic deformity, or it may be the rigid or fixed deformity. So basically, weakness, loss of structural integrity, and the deformity. These are the basic three indications. Apart from there are several indications like living temporarily can be used for the painful area part of the body. So suppose this is the orthosis can be used. They never to understand the name, parts, limitations. Now which straps should be used first? Now how far it should be tightened? So everything can be asked. So these are the this is a thermoplastic ankle foot orthosis that we use. So this is the ankle foot orthosis where the anterior trim line is anterior to malleoli. So if there is an instability of the foot joint as also the subtalar joint and the ankle joint, that is what. But whether there is only the ankle joint or the foot joints may be involved. So in that case, this type of. Now the recent advances, research and recent advances. There are several questions. Like what are the types of research we have done? Samples, sampling techniques, formulation, level of the evidence like that. So I'm just going into an example like this. Suppose this is the case. This is one student, my student. They have submitted the thesis on this evaluation of the functional and the radiological outcome in intra-articular calcaneum fracture managed with minimally invasive surgical treatment in adults population. Okay, so this is the actual topic. So this is here. These are different components of the title. I'm not going into detail. So everything is covered. But see, these are the goals. That is restore the height and length, everything. But just I want to pinpoint in the next slide. So basically, what is the aims? He has written the aims to achieve this satisfactory reduction of the subtalar joints and the stable internal fixation by minimally invasive technique. But he didn't mention the which fracture they are using. Subtalar joint is basically he missed to use this. This is a displaced intra-articular calcaneal fracture. So that there is a fallacy. Next point here he has written evaluation of the efficacy, limitation, and complications of such procedure. Again, you have to mention which procedure we are telling. It is a minimal invasive surgical technique, or the operative technique, or internal fixation technique, everything. So this is the fallacy of the aim. Now he has written the objective. So objective is relatively good. He has written. So actually, to fulfill what is the purpose? To fulfill the aim, we have to break our different parts to fulfill the objective. Like so, see, I have written to evaluate the efficacy of the minimalistic technique for satisfactory reduction of the intra-articular fracture. Now, remember, once we broke the different your study in different objectives, you have to make a tool for assessment of that, for fulfillment of the objective. So suppose this is the tool. This is objective is how to make whether the minimal surgery is sufficient or efficient enough for satisfactory reduction of intra-articular fracture. So what is the tool? Tool should be actually paraoperative parameters. That is paraoperative parameters to be set by the strategical viewing of the radiological viewing of the fractures after its reduction with the help of the C-arm, as also postoperative radiological criteria. This is the tools, paraoperative criteria, as also postoperative radiological criteria. These are the tools. So that is how you can be asked. So what are the objectives? What are the aims? The examiner may ask, and what are the objectives, and how the objectives are fulfilled with the specific tools. Suppose this is the last tool, about the fourth tool. See, you can see the fourth tool to evaluate the efficacy of the minimal invasive technique, the intra-articular fracture of the calcaneum for satisfactory recovery of the ankle and subtalar joint motions and also the functional motions. So what is the tools? Tools are the different tools are there. The most you can this is like the AO fast tool. The AO ankle foot or tools for criteria of analysis that can be used for that. So this is the objectives. I'm not going into detail. Now the specimen. So if you get the specimen, then we have to identify we have to macroscopic examination, maybe microscopic examination. The macroscopic examination, maybe some identify the parent bone. We have to identify the lesion. There is a nature, whether it's a benign lesion or the malignant lesions. We have to check the location in the epiphysis, metaphysis, or the diaphysis. We have to check the, suppose it is sequestrum you have given, we have to check the sequestrum, which type of sequestrum, what is the cause of sequestrum, what are the fate of the sequestrum, and also the management. Suppose you have got the spine, then you have to check whether it is a cervical spine, or is the dorsal or the lumbar spine, what is the location, it may be dorsal lumbar junction, it may be infective or the neoplastic, how much vertebra is involved. These are the questions. Suppose it's a microscopic, suppose a slide is given, suppose it is giant cell or the bacilli or the malignant cells, we have to identify with explanation. What is the, then may be asked, what is the cause, what is the management? So suppose this is a sequestrum, as you can see here, we have to identify it physically and radiologically, in which age it is common, especially in the immature age. See, this is a long tubular sequestrum, which is common in the younger age. So this is, you can tell what the types, fate, diagnosis, and the management. Now, see, this is a specimen of the spine. So can we ask, what is the preservative? So how to know which, is it a cervical spine? No, see, this is the spinous process. So in the thoracic spine, its spinous process is horizontal, but the lumbar spine is going downward. In the upper part, it is a little bit horizontal. In the lower part, it is a downward. That means it may be a dorsal-lumbar junction. So it is a dorsal. Some in the upper vertebra may be dorsum, lower part may be in the lumbar region. But now say check the intervertebral disc. See that intervertebral disc one. So suppose this is the body. Now where is say this is the vertebral body. So where is the disc? Disc is damaged. So the intervertebral disc space is damaged. Most common cause, it is a Carey spine. So it is a dorsal lumbar junction, Carey spine specimen. Now there are several questions that we ask, like a commonest site of why it is a commonest site, why the two vertebrae involved, what is the fate and diagnosis of management like this. Now preservative is basically, it is used as a potassium acetate and glycerin with distilled water. There are several, you can remember it because it may be sometimes it may be asked in the examination. Now this is the bacilli. You can see here in the it is a acid fast bacilli. As you can see, it holds the acid fast. It is the stain in even in the presence of the acid because of the mycolic acid in its outer layer. So it is a Mycobacterium tuberculosis, and this is the tubercle, as you can see here. And see, this is typical. It is a giant cell with the how to identify it is a Langan type of giant cell, because the nuclei it is located in a horseshoe-shaped manner in the peripheral part. So this is a giant cell. So this is basically it is a tubercle. Now the question is, what is the most important cell inside the it is the tubercle. This is the epithelioid cells. Epithelioid is the most important cells. It's the hallmark of diagnosis. Okay, now I'm not going into detail. So this is, suppose this sort of questions it may be asked. What is it? See, this is upper part, it's a very shiny. It is almost as a cartilage. In lower part, it is rough. It may be bone. So it's an osteocartilaginous specimen. That may be the different. You can tell it is a exostosis, or it may be a loose board. So maybe exostosis, that can tell what are the different other cartilage tumors of the bone. If it is a loose body, what are the differential diagnosis? There are several differential diagnoses. You can ask what are the different types of loose bodies, like osteochondral, chondral, fibrinous, or the unclassified. Next, see this sort of specimen can give. Then what are the, we have to identify the parent bone. You can check the cross section. Is the cross section? It is a triangular. It may be either femur or the tibia. So it may be a giant cell tumor. You can see here is a central expansile lesion extending up to the lower end. So it is a epiphyseal metaphyseal lesion. So it is a fleshy. It is a loculated. So it is most probably it is a giant cell tumor in the. So this is the way we can diagnose. I think I should stop here and invite to have some questions from the students. Over
Yes.
to Janki.
Yeah, thank you so much, sir. It was quite extensive lecture and very informative also. So, few common doubts which examinee used to have during practical examination. How much important for them to bring the thesis, and is there any relation of Viva with the thesis also?
Absolutely. That is why I highlighted one thesis which was done under my guidance. So you have to think, you have to know everything of your thesis, your study, because this is the study you have done it. So in that case, you have to ask which sort of study you have done. Is it a prospective study, retrospective study, is it experimental study, or is it a quasi-experimental study? If it is a experimental study, if you have done is a control group or randomization. If it is doing the randomization, which sort of randomization you have used, everything you have to know. So suppose it is a specifically purposive sample you have used, then you have to ask, so how will you have taken the purposive sample, by the inclusion exclusion technique, or by specific choosing some snowball technique, like the different types of techniques are there. So it is extremely important to carry your thesis to you. And sometimes the examiner, you have to submit the thesis sometimes in the MS orthopedic examination. So and the examiners will ask by noting the what is the different pros and cons of your thesis.
Okay, sir. So another thing is about the logbook. Do you ask for logbook also, or is it just okay if candidate do not bring that?
Yes, actually, the logbook in most of the centers, it is customary to submit the logbook, and usually in the table 5, it is usually not asked. It is from the logbook, usually it is not asked. But if the candidate is extraordinarily very good, then the examiner may check whether he has done properly or not, whether it's theoretical or not. So in that case, he can ask. But otherwise, a logbook is usually not is important for the table 5.
So for a DNB candidate, if the thesis is not accepted, that also makes any difference for the result?
Definitely, these are very good questions. Actually, the essence of the DNB is, so there's segmentation of the marks. Marks are segmented. That means suppose in the long case or any case, so there are some questions, some marks are given for the written, some marks are given for the history, some marks are given for the methods, and some marks given for the diagnosis. So what I want to mean, so sometimes a clinical diagnosis may be wrong. Maybe there are some differential diagnosis, and the candidate is our student is telling the fourth important diagnosis. They are not telling the most important diagnosis, but he will get the marks because they always segmented. The examination is segmented. That means if he have shown the proper technique, so he will got the marks in this technical part. If he tell the exact history, yeah, without tampering, he will get the mark. If he done the proper examination in his writing, he will got the mark. Now that there is the writing is now importance of writing is going to become very less. All the cases have become equal mark. So as it is, my point is, if it is marks is segmented, so it is very easy for the DNB. You don't worry about the DNB. Now it is very scientific and very very useful for that. Even if you make a wrong diagnosis, then don't become disheartened, because you will got some mark from that always.
So my question was, if the thesis is not accepted, even that part, the DNB used to ask the examinee to appear for the practical. In that case, is it make any difference in the result of practical if the thesis is not accepted? Yes.
No. Actually, in most of the situation, once the thesis is accepted, now they are allowed to appear in the examination. This is the most usual situation. Without acceptance, they are not going to become allowed. Sometimes there are some rare situation where there are some thesis is given somewhere, but it is incomplete, like that, incomplete, or the results is not come. Then and you are allowed to appear in the examination, but that result usually withheld till the thesis is going to become finalized. That is the problem.
So you have shown few cases of the tumor also in radiology section of the Viva. The one confusion, sir, which usually the candidate have is for like malignant tumor. Is it a moth-eaten or permeative? Both is lytic. So how to differentiate these two and how to say in the examination that it is moth-eaten or something else here?
Yes. So basically, point is how to identify a benign lesion or a malignant lesion. This is most important. First,
Yes.
the very basic questions. Now, how to know the benign or malignant? That means there are some radiological feature of malignancy is the cortical break. There is a wide zone of transition. Wide zone I already mentioned. Where you cannot make out where the tumor stops and the normal bone starts. That is known as the zone of transition. If we easily clearly make out that this is the area of border. It's border between the tumor and the normal side. This is clear situation. That means it is much more benign. Now this border may be sclerotic, border may be non-sclerotic, or it may be diffuse. The three types of border or margin. If it is sclerotic, that means it is either a benign lesion or it may be a abscess. It is a well organized abscess which is dormant. But initially it was an abscess, now it is healed with some deposition of the parent bone. That is why it is sclerotic. Okay, either infective, controlled, or it's a benign lesion. Again, if it is a margin, it is well defined, but it is a non-sclerotic. That means maybe very highly vascular. It is highly vascular. That is why it is non-sclerotic. Or it may be a benign lesion, but it is going to be a malignant, like GCT. GCT is going to, once it's going to be a malignant, then its border becomes non-sclerotic. It is narrow zone of transition, but it's a non-sclerotic. But if it is a wide zone of transition, that means definitely it's a malignant. Now the pattern of destruction may be geographic, or it may be moth-eaten, or it may be diffuse. Geographic means what? Geographic means suppose in our world map, we can easily understand where is the India. We can ideally identify it. Where is the America? Where is the China? Where is the Russia? We can clearly identify. That means the same thing I'm imposing on that. That is zone of transition is well defined. So it is a geography. Geography is good. But if it is a moth-eaten means it's irregular. I cannot make out where it ends. Moth some lips are relatively destroyed with the help of by eating some moths. That means the irregular border. I cannot make out where the India ends and where is the Pakistan start. Where is the India ends and where Bangladesh starts. That means it is irregular. That means it may be a moth-eaten appearance, and that may be a sinister significance. That may be so the most common is a Ewing sarcoma, is a moth-eaten appearance, or it's a malignant tumor. It's metastatic malignant tumor. It's a moth-eaten tumor. Okay, and if it is a diffuse, you cannot make any border that is significantly malignant, or it's a spreading infection. So this is the way you can go for that.
So the permeative is highly malignant, sir, and moth-eaten is little lesser than that.
Yes.
Okay, and if we say the geographic, that means benign here.
So it is, yes, definitely.
Okay. So one question about what is you mean by endosteal scalloping, asked by one of the candidate.
Yes. Actually, basically, the bones has a typical character radiologically. If it is a normal bone, the cortex, it is a uniformly thickened. Medulla, it is a uniform character. Uniform character means what? It is either uniformly lytic, or it may be uniformly. There are the different radiological character. Maybe either completely black, or it is a completely gray, or completely white. Like that is a homogeneous character. That is known as homogeneous character. So cortex uniformly thickened. But sometimes it is cortex is much more thickened. Sometimes it is little bit less thickened. That means irregular. That means there are some abnormalities. Similarly, in the endosteum, this scalloping means what? It is somehow it can be taken out. It is taken out. Some part of the tissue is taken out. Scallop means taken out. That's okay. So if it is in that area is much more lytic, or that means in the, some part of the endosteum in the marrow is much more lighting in the than the surrounding. That means it is taken out, scalloped, some taken out. So that is very sinister signal, maybe due to local infection, or it may be due to local malignancy, or deposition of some other tissues than the normal marrow. That indicates. That is not a scalloping.
So one common thing, the fear of going for Viva. Usually, if you're a first candidate, it is more. So what are the advantage and disadvantage for the candidate who is going first, sir?
Yes, it's a very common psychological problem. Yes, in the first candidate, there is some problem for the student, not for the teachers. I'm telling for that student who is going to become, which is the opener. He may be very much little bit anxious, but he is very fortunate because the mind of the teacher is fresh. Always teachers always try to ask the question from the basic one. Always, all the teachers means they always start to from the basic questions. So the first candidate, they will face the basic questions, and the point is the last candidate. That means he may be psychologically very strong, but the problem is all the basic questions has finished. That means there are psychology of the teacher is as all the basic question finished, I will ask for a new questions. That means that will be a little bit tougher. Okay, so being the first appearance, it is much more. I think it is much more beneficial than being the last candidate.
So what are the mark distribution for the Vivas? Although
Normally,
you have
what is
explained
happening in the most of the cases, in most of the situation, there is 50 marks for each table. 50 marks, and each table there are two items are usually added, like the X-rays. In X-ray, there are the trauma and the disease. For the trauma, it is 25, and the disease is another 25. Sometimes some examiners they have used two trauma cases, two disease cases. In that case, 25 again it is divided into 2, and at 20 another 25 is divided into 2. So that will depend. Okay, suppose there is a orthotics prosthetics. Usually orthotics prosthetics table, it is in that table the recent advances or the research it is usually added. So in that case also orthotics prosthetics, it is at 25, and the research is also another 25, or if it is a 4 item, that is a orthotics prosthetics plus research plus recent advance, then it is a 25 plus 12.5 and 12, like that. So in this way, that is the marks is divided.
So for DNP, because the OSCE is taken half of the marks, so how it is distributed
in the DNPs is basically it is in the first part is OSCE. In OSCE, there are I think 150 marks is allotted for the OSCE, and the rest 150 marks is divided into either a virtual case or a real case and the table 5. Okay, so in that case 150 marks is for the OSCE total. Initially part is over, and now it is going to become, I don't know, I'm not sure about it. Now it is going to become much more marks is going to become come to this virtual part.
So I was one invigilator for one of the exam. In that case, they put 10 marks for each table. 4 tables was there,
yes.
And rest 110 marks for the cases. So and
yes,
so it is also
another. So there is a 300 marks. So 150 marks for the OSCE. Then you're right, now another 150 marks. That is what 10 marks for the each table, and that maybe 10, maybe 20. Maybe that will differ.
And one more thing, sir, for the ward round also they used to keep some marks, but for that center it was not allowed.
So, yes, that will depends on that depends on. So initially in before any examination, there is an examiner's meet is done, examiner meeting, and in the actual distribution is decided in its examiner's meet.
So one thing you have explained in the X-ray about the adequacy of the X-ray. So what is the adequacy, sir?
Yes, adequacy is already told. Actually, that depends on if it's a long bone. So in the long bone, it should contain the joint proximal and joint distal. That is most important. That is the adequacy. Suppose there is a here, there is a any pathology of the hip joint, we have to take the adequate standard radiograph of the pelvis. That is the standard radiograph of the pelvis, including both the hip joints APV. This is the adequate. If it is taken the half of the hemipelvis is inadequate. Or if it is not standard, that means how do you know it is a standard pelvic radiograph? That means this your sacrococcygeal joint will touch the symphysis pelvis, and there will be symmetry of the both the obturator foramen. So this is the basically it is a standard that is known as the adequacy.
So if there are not two view is given to the candidate, they can tell that it is inadequate for them, or
yes, we can tell that this is a hemipelvis, or it is a radiograph of the only the femur, only with the knee joint. That is a hip joint is not there. Without, now we can tell it's a radiograph of the femur with the knee joint only, with the knee joint only.
no,
So
if sorry sir, just I want to ask, if there is not lateral and AP view, it is just one view is given
you can
in
tell
the
it's only
examination.
AP view. Suppose I'm telling what is the problem is, suppose suppose this is a avascular necrosis of the femoral head. So in that case, we have to see the lateral view. So in that case, you can tell it is a say, sir, it is a standard radiograph of the pelvis, including both the AP view, showing the features of vascular necrosis, but I have to see the lateral view for complete diagnosis. Why it is important? Because you have to check the lateral view also. There are some abnormal sclerosis, and the part of the amount of the amount of sclerosis, because that then only we can ascertain the actual necrotic angle for the planning of the diagnosis. An amount of the necrotic angle of Carbol, you can diagnose, you can suspect it only for the view, but we have to check for the lateral view. And also lateral view is also important for diagnosis of the pseudo fracture level. That is the pseudo fracture, subarticular pseudo fracture level. So, sir, I want to check the lateral view also for confirmation. So this is the answer.
So, one more thing, sir. Is there any table or any part of the Viva is about the surgical approach also?
Yes, surgical approach is given. I've already told that. Suppose there is an instrument table. Instrument table, there are surgical options are given in a lottery like that. It is written in a small sheets of paper, folded paper, and along with the instrument. So once the instrument is covered up, then you have to the student may be asked to pick up any that piece of paper to check that if there any impression is there. Then you have to describe that operation. Yes, operative technique is there. Similarly, in radiograph also, sometimes with flying oral may be added with that. Suppose flying oral means I'm telling that suppose a 7 years old girl present with painful swelling around the elbow joint following outstretched hand. So how do you approach the case like this? With flying oral, questions may be asked.
And so there are a few confusion when the very common thing like wrist drop splint, if it is given dynamic or static one, which one is used in which cases, like wrist drop splints.
Yes, it is very good question.
Yeah.
It's a very good questions. Extremely good questions. First of all, the suppose a coca splint. Basically, there are two coca splint. One is static, another is dynamic. Okay. So basically, for the and again the static coca splint. Static. There are three types of static coca splint. One is the short coca. Short coca is only this. Basically, it's a wrist splint. It's a wrist orthosis. It only supports the wrist. And at the long cock-up, it is the wrist hand orthosis. That is, it supports whole of the hand and the wrist. Now there is another another static cock-up, which is known as the short long cock-up. Short long cock-up. That means it only covers only up to the base of the proximal phalanx. Base of the proximal phalanx. Okay. So before coming the dynamic cock-up splint, the short long cock-up is used for the radial nerve pulse. Why? Radial nerve pulse basically is actually we have to want to support the muscles which is supplied by the radial nerve. So basically, what are the muscles? That is the wrist dorsiflexors, as also the dorsiflexors of the metacarpophalangeal joint, not the extensors of the finger. Extensors of the fingers are different. They are the lumbricals interossea. They are supplied by the different nerves. Okay, so that is why we have to support the wrist joint as also the metacarpophalangeal joint, not all the finger joints. If we support all the finger joint, then we are negating the function of the other northern nerves. There is a lumbrical interossea. This is not desired. That is why before coming the dynamic cock-up, they are using the short long cock-up, where the extent is just up to the base of the proximal phalanx. That's just distal to the metacarpophalangeal joint. The metacarpophalangeal joints are kept extended. It is supplied by the extensor digitorum, which is supplied by the radial nerve. So that is this is a short long cock-up. Okay, so that is why. And now what is the purpose of the long cock-up? That is it is used for the tendon injury. Where the tendon injury is for the initial period, you can use that. After that, we have to remove the initial part for the movement. So for the initial part, just after repair of the long extensor tendons, we have to keep the long cock-up. Again, for the short cock-up, similar simple thing like the carpal tunnel syndrome or any painful condition of the wrist, the rheumatoid wrist, or any painful condition of the wrist, we can use the short cock-up. So this is the indication. Now, for the radial nerve, the base splint is the dynamic cock-up. Why? Because that will help in agonist-antagonist synergism. What is that? Agonist. This is the principle of agonist-antagonist synergism. What is that? This is the principle. Principle is once the one muscle contracts, the opposite muscle relaxes. So if we dorsiflex the wrist, the palmar flexure must relax. And that relaxation is also an active process. That means the dorsiflexion, once the dorsiflexor is the action potential generated on the dorsiflexor muscle, that will go reciprocally on the other side. On the other side, and to tell this, we have to relax. This active relaxation is also an active process. That will causes this electrical stimulation. So that is why if we make a continuously passive stretching, active stretching by the flexor muscles, that stimulation, electrical stimulation generated on the flexor muscle, that will go reciprocally on the other side, on the dorsal side, and that will help in, that will act as the natural electrical management, electrical therapy. So that is how this is known as the agonist-antagonist synergism. That is why the dynamic cock-up is the best splint for the radial nerve.
So just one question before closing today's class is about, sometimes they have asked about the pioneers of orthopedics during the Viva or even the theory. So what all names are important to know? Yes, and the contribution is?
Yes, definitely. It's a very, very good questions. So it is, I should advise all the students. You have to make a list of the names, specifically those who are great contribution, like the Howe and Thomas is an extremely good contribution. Sometimes it is asked. Now the Milwaukee, is it a name of the person or is any name of the places? Is a very, very common question is asked. So this is a nomenclature. Nomenclature, you have to, this is extremely important. Lake Kalparthis, Lake Kalp, which is the one person or the multiple person. Putti Platt is one person or multiple persons. So we have to understand. This is we are making a list of that eminent orthopedic surgeons, and what are the inventions done by them? Is the multiple inventions. The Volkmann, suppose it's a Volkmann's fragment. Volkmann's, what is the Volkmann's canal? What is the Volkmann ischemia? What is Volkmann's ischemic contracture? What is the Volkmann's fragment? So these are usually questions asked in the examination. So make a list and make a contribution. So for we can easily answer this.
And any Indian contributors, sir?
Definitely, Indian. There are different Indian contributors, like the joint replacement. In the Mumbai, there is a
Talwarkar, yeah. Talwarkar, sir, yeah.
Talwarkar. There is another is Talwarkar's nail. Nail is there. Yes. There's a square-shaped nail.
Yeah, even for bipolar in India.
Bipolar, yes, bipolar. Yes, yes, Professor Bakshi.
Yeah.
Okay. There are several inventions are there. Okay. So Dr. There's Jaipur food. That means Dr. Shetty.
Yes.
Dr. Shetty. Dr. Shetty is extremely important. Now there is there is surface arthroplasty. Who is that? That is Dr. Bosch, Mr.
Okay,
Bosch. Surface
Okay,
arthroplasty
Okay,
from Chennai. So we have to know the different Indian authors from Indian authors.
Okay, sir. We'll try to make a
Dr.
class
Kothari,
if
Dr.
it is
Kothari,
possible. Yeah.
Raquel Kothari. This is the Kothari's method. Kothari's method, yes.
Yes. So probably we will have a class on that one if you agree in the future, sir, whenever it is possible.
Yes, yes.
And sir, you are initially was telling about some PG course also.
Yes, it's
which
it is
one?
a very good news because we are starting to form a PG course, especially for improving our skills, because this is the skill improvement is our motto of our honorary our president of Indian Orthopedic Association. So in the photo commemorate for that, we are starting. We are me and the Professor John Mukhopadhaya, we are jointly we are to make a common platform for basic improvement of the skill, especially for the different fractures, the upper limb and lower limb. There are two physical program. Basically, that one program will be on the West Bengal, another will be on the Bihar, and from Bihar, Dr. Janki will coordinate, and from West Bengal, Dr. Rajiv Raman will coordinate, and we'll make a program for the upper limb fractures and the lower limb fractures, and in the whole day program. So this is, I think, it is a physical program. We are trying to make organize it. So from a basic osteosynthetic program, program on osteosynthesis from upper limbs and the lower limbs. There will be 2 programs and 6-monthly interval. So I think if any postgraduates they want to come, they can join either in the Bihar in the where we'll discuss, we'll announce it, and or in the West Bengal.
Okay, sir. So I think we have covered most of the things, sir, although it is always incomplete when we are preparing for Viva. So, but it is a very compiled and almost everything is there. So if any doubt will be there, we will even in the future also will clear with sir. So thank you so much, sir, for the, yeah.
You will meet again.
Yeah, thank you so much, sir.